with this said, let's move a little bit more to therapy. And understandable, the easy one is a small disease, take it out, and of course surgery. And if anything, a small disease but bad liver, we might go ahead and consider transplant. And the question, however, that comes from the standpoint of the medical oncology, anything else we can do there? And Mark, I will probably ask you to please refresh all of us. Any role for adjuvant therapy in that setting after surgery or resection?
I've never seen a trial that showed that it worked. So it's all toxicity, no benefit.
Yeah.
There was a study from the late 90s in China where they gave radioactive iodine intraarterially to the liver after resection. It had benefit. That's the only one I ever saw that was positive.
Yeah.
And there was negative data from the STORM trial recently with adjuvant sorafenib showing no survival benefit. So I know that there's a trial now underway with nivolumab that's trying to look at that question.
Sure. So let's hold on to make sure that our colleagues follow us one step at a time. So by all means, historically, adjuvant therapy was always attempted in regard to the therapy for patients with resected HCC. Historically, there has been quite a bit of activity in regard to retinoic acid that came out of Japan. We heard about the effort that came out of Hong Kong for the use of iodine-131 embedded in the liver directly. But interestingly, short of a prolonged tail in regard to benefit from the retinoic acid, we don't have really any evidence for a standard of care in that regard. And then, exactly as we just heard, we have an advent of the use of sorafenib, which we're going to talk about in regard to systemic therapy. It was tried in adjuvant setting, and it's really also did not show any benefit per se. There's more things that we're going to be talking about, and we'll comment a little bit further about adjuvant therapy once we touch on the usage of different therapies in regard to advanced disease, because understandably, when you have disease that looks like very promising or either already delivering what it promised in regard to metastatic disease, by all means, one of the efforts is, could it be also used adjuvant therapy? And there's not really particular in regard to HCC. This is what we use across the board. But at least for now, I totally agree with Mark, is that really there's no standard of care adjuvant therapy in HCC, short of course is if there's any clinical trials. And by all means, as we just heard, there's a trial that could be going on, or maybe already you're probably aware of, in regard to the usage of nivolumab versus best supportive care in regard to HCC, and this or any other trial that you might have access to, by all means, you are encouraged to do so. With this said, the second layer in regard to the way multidisciplinary teams will work after we address what we have to address in regard to local disease that can be resected, that can be transplanted if the disease functionality is not at its greatest, even though here there could be a debate whom to transplant, whom to resect, that can have different opinion between the surgeons and the transplant surgeons. But nonetheless, then we come to a very important category of the patients with locally advanced disease, i.e. they are not resectable per se, but on the other hand, they don't have metastatic disease per se. And if anything, a lot of work has been done even before any systemic therapy has been established for that disease, especially along the lines of embolization. And maybe I'll ask, Amit, you can please help us first, tell us, what's embolization? What do they do?
So there's chemoembolization and radioembolization, and simplistically, these are basically both arterial-based or catheter-based therapies, where you inject beads that either have chemotherapy or radiation therapy.
How do you do that?
So you basically go in through the femoral artery and then go up, and you follow the catheter into the hepatic artery, and it goes into branches of the liver tumor. This is essentially taking advantage of the dual blood supply of the liver. So the background liver is getting its blood supply from the portal vein, whereas the HCC is getting its blood supply from the hepatic artery.
This is what I always remember. Cancer is finicky, loves clean blood on the arterial. You're absolutely right.
So if you can find the branches of the hepatic artery, then these beads that are embedded with chemotherapy or radiation therapy go into the HCC and target that selectively, and you can spare the background liver.